We are moving ahead with the next session, that is a panel discussion on how robotic technology improves the endoscopic capabilities of a surgeon. I request the panelists to come onto the stage. Dr. Divya Awasthi, she's a senior consultant OBG, Fortis Hospital, Mohali. Dr. Kanika Batra Modi, she's a gynecologist, senior consultant, Max Institute of Cancer Center, New Delhi. Dr. Marium Anjum, she's Associate Professor, Gynecology, Department of Oncology, Laparoscopic and Robotic Surgery, Yenepoya University, Mangalore. Dr. Sauna Raina, she's the Head and Clinical Lead, Department of OBGYN, Narayana Health City. And Dr. Ankita Jain, she's a Consultant Surgical and Gynae-Oncology, Venkateshwar Hospital. I now invite the moderator, Dr. Mala Srivastava, onto the stage. She's Head of Gynae-Oncology Unit, Senior Consultant and Professor, Gynae Endoscopic and Robotic Surgeon, Sri Gangaram Hospital, New Delhi.
I thank Dr. Ruma Madam for having me here to have this panel discussion. There are no videos, just a simple panel discussion, and I'm sure you all will enjoy this panel discussion. So how robotic technologies improves the endoscopic capabilities of a surgeon? We are all clinicians. At the end of the day, we want to give the best surgical outcome to all our women, all our patients. Whether we do an open surgery, whether we do a laparoscopic surgery, or whether we do a robotic surgery. We have been introduced to our esteemed panelists. So first planned hysterectomy was a vaginal hysterectomy performed by Osiander in Lower Saxony in Germany in 1801. Since then, the techniques of gynecological surgery have been significantly enhanced and the complications reduced. Laparoscopy was introduced in gynecology in 1940s for diagnostic purposes and then later for tubal ligations. In 1988, finally, we had LAVH, and robotics came in gynecology in 1999. So robotic surgery is nothing but an innovation, a tool in our operating room. And of course, it is being widely advancing day in and day out. So Dr. Sapna, laparoscopic and robotic surgeries, are they different? And why do you think they are different?
Thank you, Dr. Mala. Thank you, Dr. Ruma. I mean, let me have the opportunity to thank her for inviting us as faculty. Coming back to the question, I think this question has been the hottest since morning, and whether laparoscopy and robotic surgeries are different or not. I believe, like, although robotics as well as laparoscopy, these are the different modes of minimal invasive surgery, yet these are miles apart. I mean, this starting from the port placement, strategization, coming to the conventional laparoscopy, wherein we are using rigid rod-like instruments, viewing the surgical area on the monitor. Now, this does require a lot of hand-eye coordination. The instruments are counterintuitive movements, like in the sense, like if the surgeon is moving hands in one direction, the tools are going to move in the other direction, the opposite direction. This definitely requires a lot of psychomotor skills, which requires years of training sessions. The instrument tips used in the conventional laparoscopy does have restricted mobility, only 4 degrees motions are there. And then the surgeon has to be highly dependent on the expertise of the assistants, right? So that means you really need to develop a robust team of doctors who have, who are well coordinated, so that you can have a seamless conventional laparoscopic surgery. Whereas if we look at the robotic surgery, the surgeon is sitting comfortably in a ergonomically designed surgical console, looking into the 3D magnified vision of the surgical field, taking the control of all the instruments as well as the camera. So that is like the surgeon can have a minimal assistance from the bedside assistant, right? Moreover, the instruments, these are intuitive. That means, like, I mean, if the surgeon is moving hand in one direction, the tools are going to move in the same direction. With the endo-wristed tips of the instruments, it's just like using your, human hand while performing an open surgery, or probably better than that. But then there are certain differences with respect to cost. Now, talking about cost, laparoscopy, it's a kind of a one-time investment, whereas that is not the truth with robotic surgery, where, it does have a recurring in, cost factors, drapes, arms, which needs to be changed at a regular interval. Not only that, it's the storage as well, I believe, like, robotic instruments and the robotic system, it's just like a Hulk. You really need to dedicate a whole room to store it when not in use.
So we'll move on to the next question,
yeah.
Dr. Marium.
Yeah.
Why learning curve is longer in laparoscopy than in robotics?
Good morning,
give a
ma'am.
short
Good morning,
crisp
everyone.
answers.
Yeah.
So, as Dr. Swapna has told, I think the learning curve is very much shorter in robotic surgeries. It's probably because one is because of the contuitive, as she told, intuitive and the counterintuitive movements. So it's exactly the opposite what we do in laparoscopy, whereas it mimics the same when it comes to the robotic surgeries. Another one is you're totally independent of the person who is assisting you. Like we have the residents, sometimes you have the interns, sometimes there's no one except for the scrub nurse. So when it comes to robotic surgeries, it's like the camera is totally under your control. Your assistant arm is totally doing everything for you. It just moves the way you want to. Unlike laparoscopy, at times you just kind of lose temper because the assistant may not be showing what you actually want to see. Another is probably the vision, the 3D vision, the ergonomics, the comfort of your sitting and doing these surgeries. And next is the accessibility. You can go actually to the close. It's more of an immersive vision. It really feels like you are sitting inside the abdomen and doing these surgeries. Because out of my own experience, I actually, after doing robotic surgeries, like my proficiency is increased more in case of laparoscopic surgeries. And I really felt that the learning curve is very short. Must be like 5 cases or something.
You mean to say if you're doing robotic surgery, you can learn laparoscopy much faster?
No, it actually complements each other,
Yeah,
but then my
definitely.
proficiency has actually increased more in laparoscopy after I started doing robotic surgeries.
So Dr. Kanika, how many of us has been doing laparoscopic surgeries before we started robotic surgeries? Do you
I think, yeah, most of us have been, a conversion from laparoscopic surgeons, and it took us some time to really see the value of the new technology that has come in. Almost everyone has been doing minimally invasive surgery with laparoscopic surgeries, and you really had to see the worth of why should one make the patient pay extra in order, what is the benefit of it if I am a good laparoscopic surgeon. So it took me really long, despite having been trained in robotic surgeries. It's only for the last 1.5 years that I've been proficiently doing robotic surgeries because I understood the value late. And if you ask me now if I want to go back to laparoscopic surgeries, the answer would be no.
That's great. So Dr. Divya, what we had to unlearn from laparoscopic surgeries and learn in robotic surgery?
The major differences between doing a laparoscopic surgery and robotic surgery, what I found was the vision was very good. It was 3D vision, and the camera is under your control. You are not dependent on the cameraman. And another mega difference that was there was the 3-arm wrist movement, 360-degree movement. So what I had to learn was in laparoscopy, the instruments are straight. We go straight to the field where we are operating, and we are not using the wrist movements. So in robotic surgery, initially what I was doing, I was not utilizing that movement. So I had to unlearn that thing in laparoscopy and do it, utilize the 3D movement, 360-degree wrist movement in robotic surgery. And another was camera adjustment, because it is under my control, and I have got 3 operative arms, and I have to control all the arms. I need to be very attentive where I need to move the arms and how to adjust the camera. So these are 2 major things which we sometimes find to unlearn and relearn in robotic surgery.
That's great. So Dr. Ankita, do you think your OR has to be modified to accommodate the robot?
Thank you for the question, ma'am. So I believe that the robot can pretty much be adjusted in our usual OTs, except that there are certain things that we need to be careful about. Like we need good enough space to accommodate the robot, because We need a space, dedicated space for the console where the surgeon can see the table, and we need the space. We need to move the arm cart around the OT. We might not always position it in the same place in every case. Apart from that, we need internet connectivity, and we need enough power sources. Like for the Medtronic system, you need almost 5 power sources to make sure that it's up and running. And apart from that, maintaining the temperature and humidity of the OT are essential for smooth functioning of the robot. But apart from that, I don't think we need anything special or extra to be done in our OTs.
See, Dr. Sapna was saying that it is a hathi. Like, yeah,
Yeah,
basically.
I agree.
So now the newer system are coming, which are individual arms. So that OT can be converted into regular OT as well. And not only it can be a dedicated robotic OT, it can be used for other surgeries as
Yeah,
well.
but these...
It makes sense, otherwise, moving out the cart and, getting it does take a lot of time. So as Dr. Arman was saying, dedicate one OT, make it a robotic OT. So in cases of emergency, you really don't need to, spend a lot of time in doing that.
Yeah, definitely. That is something that goes without saying, that OT has to be dedicated to it. But coming to the individual arms, I think that just increases the number of data cables that you have lying around in the OT, which is less with the arms that are not floor mounted.
So Dr. Kanika, do you think robotics should be used even for simple surgeries? Other surgeries than complex surgeries?
So, ectopic surgeries I particularly do not deal with, but yes, for ovarian cystectomies, so usually, ovarian cysts that we operate are associated with endometriosis, and for endometriosis, we do know the distinct advantage. But otherwise also, having a good vision to see and map the normal ovary and to save as much of the ovary, I think that would also be a distinct advantage. But yes, laparoscopy shouldn't be much inferior in that. So if cost is a constraint, laparoscopy one can go in for.
By and large, we think that ectopic surgeries are emergency surgeries.
Okay.
That's what
Yeah.
we feel. So ovarians, if we think it is endometriotic, or we think we will get adhesions, or maybe we want to do a more refined surgery, maybe we can switch to...
Yeah, especially when you have to suture back the ovary to reconstruct it, their distinct
You think
advantage.
that robotic will come.
Group of patients, where you want to preserve the fertility, that is important. The precision is the key word. And
Yes.
where you really want to maintain that, I think that group of patients really would like to, see whether you want to,
Because
go
the
for
general concept
precise.
is this: robotics is only for difficult surgeries or complex surgeries. But
So I
if
think we
can
need to
extend
individualize the cases. Yeah.
Extend the advantages of robotic surgery even to other kind of surgeries, benign surgeries, maybe it will be beneficial for the patient.
I think even cost also has to be kept in mind, ma'am. Like things like simple ovarian cystectomies, which we could have just got away with the 3 ports, and in a low resource setting like medical colleges and all, for us, cost also has to be kept in mind. Something what I can just do it in laparoscopy, like why would I do it in robotics? So we have to individualize the case as well.
That's the key word. You have to individualize the case. Dr. Marium, again, how your robotic outlook has improved your laparoscopic outlook?
To be frank, ma'am, both has complemented each other, right from like OR setup to OT position, patient positioning, team building, the anesthesia part of it, pneumo skills, port placement, specimen retrieval, manipulations, everything. I think laparoscopy has actually complemented for me for start off with the robotic surgeries. But when it comes to robo overlap, I think it is the instrumentation, the dexterity, the way of my suturing techniques, all have improved after I started doing robotic over the laparoscopy.
So your robotic
movement of-
technologies
yeah,
have definitely
yeah.
improved your laparoscopic skills. So robotic arms, Dr. Sapna, are they hindrance for assistants?
Yes, sometimes. So as I said, the robotic system is like a Hulk, and so are the arms, very sturdy, robust. And when we talk about the ergonomics of the console surgeon, we have to consider the ergonomics of our bedside assistants as well. Now, especially during the complex surgeries, when the console surgeon is more focused on doing the surgery properly, may not be aware of what is happening there in the bedside. So these, sturdy arms can actually hit your assistant and, can injure them. So what we do in our practice is like, we try to keep the assistant port more laterally and little cafilate, with respect to the other surgical robotic arms. That has really helped. Yeah.
So Dr. Ankita, all of the robotic system do not have ligature and harmonic. So you find deficiency of ligature and harmonics in robotics compromising your surgery?
In fact, what I've learned is only the newest system have a robotic ligature and harmonic, and I think all these years we have been using the bipolar to actually coagulate and help with the bleeding. So far, in fact, I spoke with many surgeons regarding the same, and I don't think anyone has encountered any problems as such with the bipolar. The newer systems even offer a alarm or a sound when the entire cycle of the bipolar is over, which I think is very helpful and very much easy to control bleeding. And with the newer ligature and harmonic, the cost is too much for a country like India. And you always have a bedside assistant who can use a laparoscopic ligature or harmonic. So far, I don't think we have lost anything, but definitely once we start using them, I'm sure we will find some benefit. Just like using the robot for the first time, maybe we do not identify the benefits then, but eventually we do see them. So maybe in the future we might find it indispensable.
You want to add something?
Yeah, actually I am having the SI system and I've been using over 5 years. It's been just using bipolar and monopolar, and I've been doing complex surgeries and lymph node dissections. So it's never like that I felt that I don't have a ligature. Of course, I could manage with bipolar and monopolar. This is just for the people who are just start to begin with. They need not have that inhibition key. I don't have an extended this one vessel sealer or a ligature, but it's definitely possible because there have been so many cases like previous 3 laparotomies, 4 laparotomies, complex adhesions, small bevelage, but I actually got away with just not even, I have not used even laparoscopic, which I could have used in the assistant port, but it is manageable with bipolar. I would just like to support.
So Dr. Divya, do you think integration of AI into the robotics will give an advantage?
We have heard a beautiful lecture by Dr. Ruma Sinha explaining the role of AI into robotics. Already they are doing 3D imprinting, which is helpful in sometimes there are fibroids which we are not able to visualize intraoperatively, which are intramural. So 3D imprinting allows us to identify the location and do the surgery. And especially in adenomyoma resection where the planes are not clear. So these things help us. And the cases of the automated robotic system doing the surgeries which are in research might come in future. How much they will help us in doing the surgery is difficult to say because see, AI cannot replace human touch. And but yes, because of the AI processing and the data it can handle, it can help in robotic surgery outcome.
So you think that now we, in our armamentarium, robot is an armamentarium, a tool to give the benefit of surgical outcome to our patients. And despite advances in technology and technique, there will always be the person behind the tool, which is very important. The surgeon himself, you have to be a good surgeon. Whether you are an open surgeon or laparoscopic surgeon or robotic surgeon, you have to be good in your skills. That is the most important part of any surgical outcome. And I thank my esteemed panelists who have taken this discussion to a great level. When we got this topic, we did not think what we will talk about, what we will discuss, but definitely we had thought, and our panelists did a good job in discussing each and every point. And one thing we want to tell us, we are all clinicians. Our aim is to give a good treatment to our patient, whether we take them through bicycle, we take them through a car, or whether we take them through a plane. This is definitely a tool, and we must offer the best to our patient as much to our capabilities. Thank you. Thanks for the patient listening.
Thank you, Dr.
Thank
Mala.
our panelists
And I would
who have
like
done
to
a good
take
job
this opportunity
with it.
to thank Dr. Ruma Sinha and Dr. Anshumala and the whole organizing team. Thank you very much.